MCQ live session. So I'm just waiting for a visual confirmation that I'm live. If any one of you can see me live, just put it in the comment below. All of you can see there is a live chat here. Just put it in the comment and I'll start the session for today. If you all can see me live, just put it in the. Okay, so I can see myself live. Welcome to today's session. This is session 8, and as scheduled, we are getting live at around 5 p.m. So this is a series of MCQ session which I have started for so many of my students who have kept on requesting that, sir, please take live sessions because we learn a lot more in your live MCQ sessions than in theory sessions. Because obviously, when I discuss MCQ, I discuss all the relevant point and the practical, application of whatever theory you have learned. Okay. So every week I'm taking 3 to 4 sessions, generally in the evening. So today is session 8, 2nd May at 5 p.m. Anyone who is new to this session, make sure that you subscribe to this channel and hit the bell icon because you will get a notification whenever I'm going live. Also, if you can just give this video a thumbs up, and if you have any questions from this session or any suggestions for the topic, you can just put it in the comment below. If you want your friends to be a part of this live session so that all of you can practice these questions, in the same setting, then you can just share this video with your friends. One last thing before we actually start today's session, that is our daily update on Medico apps. So basically daily through WhatsApp, I'll be sending personally, concept card, short videos, quizzes, master classes. Master classes are longer classes on high topics. Then these live sessions notification, free PDFs, mini courses. So whatever we are creating as a team, that will be available for all of you. And all you have to do is join our group. So basically, how do you join your group? So you go to medicoapps.org/groups. Okay, and there you can join your relevant group. Like if you are a first year student, you can join first year group. If you are a second year student, you can join your second year group. So whichever group is best for you, because according to the group you have joined, you will keep getting notifications from us relevant. So if you have joined a first year group, you will get only notifications related to your first year subjects. Is it okay? So now let's start with the first session for today. And this is a clinical question which actually appeared in the examination. A 60-year-old male came with history of a recurrent UTI, presents with left flank pain and hematuria. CT reveals a 1.5 centimeter stone in the left kidney as shown below. So here you can see a renal stone. Okay. On further investigation, a UTI, urinary tract obstruction due to stone was a. So what is the confirmed diagnosis? So basically they are going to ask you about what kind of stone it is. Now, which is the most common stone? Can anyone tell me in the comment, which is the most common renal stone? Which is the most common renal stone? Anyone can write in the comment and I'll answer it. Which is the most common renal stone? So we know that calcium oxalate is the most common renal stone. Okay. And in this case, which is the stone which is generally related with recurrent urinary tract infection? So we all know triple phosphate stones, also called as staghorn stones, are generally which are related to recurrent UTI. Okay, so renal stones are super important topic. So let me just tell you about a few of these renal stones. So let's talk about the first is the most common renal stone, that is calcium oxalate stones. Okay, calcium oxalate stones, we know this is the most common renal stones. And remember here, the most common cause of basically causation of calcium oxalate stone is basically idiopathic calciuria, which means there is no particular cause, but there is an increased calcium in the urine, and because of that calcium crystallizes along with oxalate to form this calcium oxalate stones. And is it radio? So for all the stones you have to know what is the pathology. Is it radio opaque or radiolucent, and what is the shape of the crystal? So in this case, remember, it is a kind of radio opaque stone, which means when you do a X-ray KUB, you will be able to see these stones. Okay. Now then we have got basically these stones can be calcium oxalate, which is like monohydrate or dihydrate stones. Remember, monohydrate stones are basically dumbbell shaped, whereas your dihydrate, calcium oxalate stones will be envelope shaped. Okay, so I'll show you these shapes in a while in an image, but this is the most important things about calcium oxalate stones. Okay, now how do we treat? So one is obviously treatment of the stones will be surgery or shockwave therapy, but how do we prevent the recurrence of these stones? So remember, we generally give thiazides, okay, which will avoid the recurrence of calcium oxalate stones. So these are the most important points which you have to remember about calcium oxalate stones. Next we come is the next class, that is calcium phosphate stones. Okay, calcium phosphate stones. So here what you get on microscopy is rosette crystals or blunt end needles. Rosette crystals, also called as blunt end needle shaped crystal. So we are going to see an image. So basically it will be needles with a blunt end. Okay. And when are these calcium phosphate stones seen? So whenever there is an increase in the calcium, for example, in hyperparathyroidism. And remember, in a hyperparathyroidism, it is not the calcium, but generally it is the phosphate which is increased. And then hyperthyroidism. And in hyperthyroidism, calcium is increased. So either calcium or phosphate, whenever each of them will increase, this will lead to increased crystallization and formation of this calcium, phosphate stones. So this is the second most important class of stones. Again, it will be radio opaque. Calcium is there, so radio opaque stones will be seen. The next important category of stones is your triple phosphate or struvite stones. So triple phosphate, also called as struvite, also called as staghorn stones. So this is the next important category. So what is it made up of? It is made up of magnesium ammonium phosphate. Okay, this is a very slow growing stone. Okay, and it gives a kind of image of staghorn. So that is why. Again, it is radio opaque. So again, when you do a X-ray KUB, you will be. The important thing is the pathogenesis of these kind of stones. So what happens is, when in our urine we have urea, and when there is an infection of any bacteria which has urease activity, for example, protease mirabilis. So this has urease activity. What it will do? It will break down this urea into ammonia or ammonia, and we know that ammonia is alkaline. Okay, and this will lead to the crystallization of calcium, phosphate, and ammonia. That is why it is called as triple phosphate stone. Okay, so this is how. And if you do a microscopy, what will be the shape of these crystals? So the crystals will give something called as coffin lid appearance. It will give a coffin lid appearance. So we'll see all the shapes in a while, but hope all of you are very clear about these different stones. Now some other stones is uric acid stones. So uric acid stones, we know that uric acid stones can be there when either there is an increased production, for example in cancer, when the patient undergoes chemotherapy, or there is a decreased excretion. So, and based on where there is an increased production or decreased secretion, we have different basically treatment. For example, when there is an increased production, we will give allopurinol, and when there is a decreased excretion, we will give propenicillin. Okay, so there are some very interesting points about uric acid stones. That is why it is very frequently asked. Number one, very important and unique point is these are the softest stones. So these are the softest stones. They are very, very soft. And then they are also, and this is what you have to remember, radiolucent. So when you do an X-ray KUV, you will not be finding these stones. What is the shape of these stones? So these are rhomboid in shape. These stones are rhomboid in shape. Okay, and how do you go and find these stones? Obviously, you can do a CT, but another very important thing is you can do a 24-hour urinary acid. Yeah, this will also help you to differentiate between if the person is the stone formation is either due to the increased production or decreased excretion. Okay, so it is a rhomboid shape. So this is uric acid stones. The next important category, and which has been asked in the exams very frequently, are two. One is cystine stones, and then there is xanthine stones. Okay. Now, cystine stones, there are some very, very characteristic features which you have to remember. Okay. Number one, these are the crystals are hexagonal in shape. So the crystals, cystine crystals are hexagonal, and it is generally caused in when there is a defect in a amino acid transporter. So di basic amino acid transporter is defective, and because of this COLA, cola amino acids are basically cola amino acids are excreted in urine. So C stands for cysteine or methine, lysine and arginine. All these have two basic amino acids in their structure, so they are excreted. Okay, so this is it, and so these are cystine stones. Remember, they are hexagonal. They are very, very, again, very important is they are one of the hardest stones. So we do not use extracorporeal shock wave therapy. We do not use extracorporeal shock wave therapy. So this is all about xanthine. And the last stone which I want to tell you is cystine. The last stone which I want to tell you is xanthine stones. Okay. So these are basically irregular in shape. They do not have any particular shape. Okay. And they are due to the deficiency of xanthine oxidase enzyme, and in that case there is basically xanthiuria. Okay, and because of excess xanthine in the A, and how do we treat it? We basically give D-penicillamine, which leads to the excretion of the excess xanthine. So these are the various. So let me show you certain images so that you will be able to differentiate microscopically. So what is this shape? So you can see this is what we call as a dumbbell dumbbell bill and dumbbell shape, and this is classically seen in calcium oxalate monohydrate crystals. What is this? So this is what we call as an envelope shaped. Okay, envelope shape. So this is basically your envelope shape. And when is this seen? So this is seen in your calcium oxalate dihydrate. Is it clear? Now, this is what we call as needle with a blunt end. So it will be needle with a blunt end. Okay. So you can see these crystals. Okay. And this we have seen it is the calcium phosphate stones. Okay. Let's look at another. So this is what you call as a staghorn calculi. See, or stur white. Completely, it is taking up the renal papilla. Very, very big stones. Okay. So this is your staghorn calculi, also called as triple phosphate calculi. And what is this say? So this is like a coffin. So envelope and coffin, this single line is the difference. So this is your envelope shape, and this is your coffin shape. Okay, so this is your coffin shaped crystals, and this again, coffin shaped crystals. Where do we see? We see is in triple phosphate stones. Triple phosphate stones. Next, we have is 1 minute. Let me rub it. So we have this, triple triple phosphate is in coffin shape, and this is your hexagonal cystine. Sorry, this is your hexagonal. Okay, this is your cystine, and this is rhomboid shape. You can see a rhombus, not very clear, rhombus shape, and this will be your uric acid. Okay, and remember, uric acid crystals are uric acid crystals are very, very sharp, so they can break and take various other shapes also. but primarily they will be rhomboid. So rhomboid is this shape, okay, and this is your hexagonal. This is your hexagonal. So hexagonal, we have seen it is in size T. Okay, size T. So again, super important is this particular topic of renal stones. So let's quickly look at whatever we have seen till now. So calcium oxalate, these are the most common renal stones, and generally the cause is idiopathic calciuria. They are radiopaque. Hyzide is given to provide reoccurrence. Uh, Monohydrate crystals is dumbbell shaped. Dihydride crystals is envelope shaped. Calcium phosphate shape, they are rosette shaped or blunted needle shaped crystals. Hyperparathyroidism and hyperthyroidism, wherever either calcium or phosphate is there, again they are radiopaque. Triple phosphate, radiopaque, and most important is the mechanism. So any bacteria or any microorganism which produces urease, so it will break down urea into ammonia, and that calcium phosphate and ammonia. So that is your triple phosphate stones. Okay, and again this will be coffee lid and radiopaque. Uric acid, either there can be increased production or decreased excretion. These are the softest stones, radiolucent and rhomboid shape. So we have seen this is the shape of your uric acid. Cysteine, they are hexagonal. Dibasic amino acid is transporter is deficient. So we have polar amino acids being excreted. These are one of the hardest ones. So we generally do not use shockwave therapy to treat them. Is everybody clear about all the stones? Okay. So let's look at the next question. So this again is a clinical question. A 47-year-old woman is brought to hospital with fever, headache, confusion, and jaundice for one. Okay. She appears disoriented in time and place. On examination, her platelet count is 25,000 per millimeter cube, and hematocrit is 24%. Okay. Creatinine, which means renal involvement, is also there, 4.9, and coagulation tests are within normal limit. Okay, but bleeding time is increased. So which of the following is the most likely diagnosis? Which of the following is the most likely diagnosis? Okay, so if you know the correct answer to this question, please write in the comment below. If you know the correct answer, all of you can just put in the comment below what is the correct answer for this. Okay, so basically here you have to know what are the differentials of this particular. Now, let's quickly, look at a very important, a table which will help us to differentiate between three, four options which have been given. So, the first option is basically idiopathic thrombocytic purpura, also called as autoimmune hemolytic disorder. Okay. Then we have got Henoch's choline purpura, thrombocytic uh, purpura, and then we have got DIC. Okay. So, basically, the etiology, if you see, this is autoimmune. Okay, if you see here there is an increased level of IgA. What happens in here? There is a specific molecule Adam TS13 which is decreased, and because of that what will happen? The auto degradation of you know von Willebrand factor, that will not happen. Okay, so there will be, and DIC, the cause is basically sepsis. Okay, now if you see, bleeding time is normal in this. Bleeding time is normal in this. Rest all the other conditions, because only IgA is increased, so bleeding time is normal in this. Okay. In fact, not only bleeding time, in Henoch's choline purpura, your prothrombin time will also be normal, and your APTT will also be normal. Is it clear? So if you look this, okay, so this is your Henoch's choline purpura. On the extension aspect, you will have purpura being developed. Okay. Now let's look at here. In idiopathic thrombocytic purpura, your bleeding time will be increased, but your prothrombin time and activated prothrombin time both will be okay. And when we talk about thrombocytic purpura, what is going to happen? Here, bleeding time will be increased, and both PT as well as APTT both will be. Is it clear? In sepsis, again, all of these will be increased, but you will have a decrease in the fibrinogen content. Is this clear? Decrease in the fibrinogen content. Now, if you look at the questions, so bleeding time is increased, but coagulation tests are within normal limit. So only one thing we have left is idiopathic thrombocytic purpura. Okay, so that will be autoimmune hemolytic anemia. Only this option is the correct option. So because you can see yourself, so all these options can be eliminated. Only autoimmune hemolytic anemia, where coagulation profile is normal, blood bleeding time is increased, platelet will be decreased. Okay, so let's look at the next question. So find out the value of LDL if the total cholesterol level is 300, SDL is 25, and triglyceride is 150. So how do we find the cholesterol level? So this is a numerical which came in AIMS examination. So to calculate this, we have something called as Fredwald equation. Fredwald equation. So what does this equation say? So this equation says that LDL is equals to total cholesterol plus minus HDL minus triglyceride by 5. So this is the formula. So we know in this case total cholesterol is 300, HDL is 25, triglyceride is 150, so 150 by 5. So this is 30. So 300 minus 25 minus 30. So what will be the correct answer? 245 milligram per deciliter. Is it clear? The correct answer will be B. So this Fredwald equation basically it establishes the relationship between LDL, total cholesterol, SDL, and triglyceride. But remember, for this equation to be valid, this triglyceride cannot be more than 450. Okay, so this is the limitation. Is this clear? So again, LDL is equals to total cholesterol. Again, I will write it. LDL is equals to total cholesterol minus HDL minus triglyceride by 5. This is given, this is given, this is given. You can easily calculate your LDL. Is everybody clear? So the correct answer here is D. Let's look at the next question. This again is a clinical MCQ, and the question is urine screening of an apparently healthy pregnant woman. Okay, demonstrate positive clinical test reaction. However, blood glucose level is within normal limit. Now, clinical test, remember, it is a kind of glucose test. Okay, glucose test. But remember, not only glucose, it can also come positive for your fat. Basically, it is for reducing sugars. So any reducing sugar will give. Primarily, we use it for glucose as a proxy to, use it for glucose. The woman has been unaware of any metabolic problem and has been living a normal life. Okay. So which of these following is likely deficient in this woman? Okay. So what does this clinical scenario mean? This clinical scenario means two, three things. First of all, there is a presence of reducing substances in the urine, but glucose is normal, and based on the options you can see fructose can or galactose can be an answer. But remember, if you see C is unaware, which means clinically it's a very benign disease. So only fructokinase deficiency, also called as benign fructose, benign fructose urea or essential fructose urea, only that can be the cause. These two have severe symptoms. Even lactase deficiency presents very, very differently. You will have difficulty in digesting milk. So the correct answer will be fructokinase. Let me quickly take you through the chemical reaction so that you know what is that. So when we talk about fructose metabolism, now fructose basically can get metabolized with two enzymes. So the normal pathway is the first enzyme is fructokinase, okay, And what does this fructokinase do? It will make it fructose 1 phosphate. Okay. Again, the normal route is this fructose 1 phosphate with the help of aldolase B. Okay, it will be broken down into glyceraldehyde and dihydroxyacetone phosphate. Okay, this glyceraldehyde can be converted into glycerol 3 phosphate, and this will further go into glycolysis. Even this can. Okay. Now, suppose this fructokinase is deficient. What will happen? This fructose can still be metabolized with the help of an enzyme called as hexokinase. Now, hexokinase can metabolize any 6 carbon sugar. So, this fructose now is converted into fructose 6 phosphate, and this fructose 6 phosphate with the help of phosphofructokinase will be converted to fructose 1,6 biphosphate, and this will be directly converted to. So the only thing that is going to happen, the only thing which is going to happen here is basically when this is deficient, now the hexokinase cannot metabolize huge quantity of fructose. So when the patient is going to take fruits, then this excess fructose will come in urine. Otherwise, the patient lives a completely normal life. Okay, and that is why this disease, when this fructokinase is deficient, this is called as benign fructosuria. This is called as benign fructosuria. Any doubt in this? Okay. This is called as benign fructosuria. Is this clear? Now, imagine this enzyme is deficient. Imagine this enzyme is deficient. So what is going to happen? All the fructose which you eat will get converted to fructose 1 phosphate, and now this does not have any metabolic pathway to go. So what ultimately it is doing? It is chelating all the phosphate. And what will happen? Because phosphate is very important for your energy transactions. Remember, ADP plus phosphate will become ATP. This is your energy currency. So when this phosphate is all chelated, this will lead to severe symptoms, and that is lead very severe. And this is called as hereditary fructose intolerance, which means whenever the person is taking fructose, he will have severe symptoms. This kind of clinical manifestation will be very early in life, and at the time of weaning, when fructose is given, that will lead to acute hypoglycemia, okay, failure to thrive, lots of symptomatic. So this, in this clinical condition, we have got the basically deficiency of fructokinase, and hence that is the correct answer. So fructokinase will be here. Now again, galactose 1 phosphate uryl transferase again will cause very severe symptoms. So the correct answer here is fructose. So this was the clinical questions for today. Towards the end, let me talk about how whenever I talk to my students, they always say that revision is the biggest challenge. And why is revision a big challenge? Because there's so many information to revise. It's super boring to revise, and even when students revise, they keep forgetting it. And so what we have done, we have created something called as concept card. How concept card is different is because we have taken only high topic, converted into images and flowchart, and made the learning very active. What do I mean by active learning? Which means a flowchart is given, it will not simply give you the flowchart. It will keep some boxes empty so that you actively think that what is filled in that boxes, and that will help you to remember better. So you can try out the download link for this concept card will be in the description box, or you can simply go to the Play Store, type Medico Apps concept card, you will find that app and you can download it and for yourself see if this helps you in revision. Because most of the students, they are not able to qualify just because of the revision, just because they are not revising properly. Even if they work hard, even if they have run from 10 sources, they will never be able to qualify. Just an end, if you want all the updates from us in terms of concept card, that is the cards, you will keep getting it over WhatsApp, short videos, master classes, these live sessions notifications, a lot of free PDFs and mini courses. Then you can go to this URL medicoapps.org/group and join us, and you will start getting, you will be added to one of our groups, and you will start getting updates from us. This is an admin post group only, which means when you are added, you will not get a lot of side talks, only high quality updates from us. So this was end of today's session, session 8. Again tomorrow at 5 p.m. we can again sit and discuss some very high yield topics. Today we have discussed 4 super important topics. So we have discussed We have discussed renal stones, super important topic for your PG entrance examination. We have discussed clinical cases related to fructose metabolism. Okay, we have talked about then we have talked about all the hemolytic disorders. We have taken over clinical cases on hemolytic disorders, and then we have taken a tile topic of lipid metabolism. So all these topics we have covered today. So again, see you tomorrow. Thank you so much, guys. Again, join in tomorrow for another such session.